Good morning, everyone, and welcome. Thank you so much for joining us today. My name is Kim Rose Sabuklalaw Ibol, and I'll be your host on today's program. It is my pleasure to welcome you all to our TB Prevention and Control webinar. So just before we get started in today's activity, let me remind you all for today's attendance. Please register on the attendance link and do not forget to answer the feedback form evaluation form after the webinar. And if you have any questions during our presentation, please chat it down or write it down in the question box. We will open up this on the open forum. So may I invite everyone to invoke into our Almighty God for our opening prayer to be followed by the national anthem.
One day I'll hear the laugh of children in a world where war has been banned. One day I'll see words of love and devotion.
The full health section. Amante. For our checking of attendance of today's webinar, let us call on Sir Amante Damayo.
Hello, hello. 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 Can I be heard? Okay, so it's now time for our roll call of the participants. So, please say present if you're around. May I call on Dr. Melvin Inerio?
Yes, present.
Dr. Celia Subere? Present. Okay, Sir Dryden?
Present.
Ma'am Kate? Ching? And
Present, Kathy. Morning.
okay, good morning. Now let us call for our participants from the field, from our field nurses. So let us start with Miss Ali Hidayah.
Present.
Miss Hidayah, are you around?
Yes, sir.
Okay.
Yes, sir.
So, sunod si Yasser. Sir Yas,
Present, sir.
present.
Morning.
Okay, thank you. Next will be Ma'am Jesseline Bakutot, our nurse from Salvador National High School. Are you around, Ma'am Jesseline? Nara. Hi, ate. Good morning. Oh, na-mute ka, te. Okay, so let us now proceed to the next nurse to be called upon, Sir Jasper.
Present. Dre, kadyo lang kay
Sir
imbitan ko po.
Jasper? Na.
Present.
Sir Jasper Damayo. Okay. Sige, thank you, sir. Sir Greg, naanapod. Si Ma'am. Okay, si Ma'am Janet. Ma'am Janet. Hello, Ma'am Janet. Ma'am Janet Ibarola. Okay. Oh, nagwapa na bata si Janet man. Next will be Ma'am Nihaya.
Present.
Present. Okay. Thank you, Ma'am Nihay. Then next will be Sir Jed. Sir Jed Makapubre.
Present, sir.
Present. Okay, thank you. Ma'am Jane, PV Jane Mapandi. Pit.
Wala daw yung signal.
Nawang signal. Okay. Na. She around?
Nagpa-vaccine.
Okay.
Naa sila. Nakapas sila.
Next will be Lady M. Hindi na. Lady M, Miss Munina, nakarayo? Ma Munina. Wala si Munina. Nara. Nara si Lady M.
Lady M.
Good morning, Lady M. Thank you. Miss, si vaccination champion, si Shai. Claire, Claire, sino May?
Present. Good morning,
Present.
sir. Present.
Okay, next will be Miss Alit. Alit Marie.
Good morning, friend. Friend, good morning.
Good morning,
Present.
friend.
Um,
Ma'am Merly Sulay. Are you around? Ma'am Merly. Present. Thank you, Te. Oh, good morning.
Good morning.
Good morning. Sunod ayon si Ma'am Riza.
Present. Good morning.
Good morning. Thank you. Si Maylin. Si Maylin Tuastumban. Are you around, Inday? Inday. Wala pa si Inday. Next will be si Ma'am Inin, Ana. Appeal ang paano? Ayos, okay. So, let us proceed to Ma'am Rusi. Are you around, Ma'am Rusi?
Present. Good
Present.
morning. Good morning, man.
si-
Good morning, all.
Sumba ta ginagmay dabi.
Yes.
Okay, thank you, si Hope Earl. Hope Earl Balugtod, are you around?
Present, sir.
Present. Good morning, Hope.
Morning,
Next.
sir. Morning, Panan.
Good morning, thank you. Si Ating, Ma'am Norulin Bauti. Norulin Bauti, mo siguro ng NBO. Ating. Madam Ating. Nara. Then, Ate Mercy. Mercy Kiamko. Ma'am Mercy, are you around? Nana ka, Ate Mercy? Si Ate Mercy. Wala, si Ate Mercy. Ate Mercy, is that you? Si Ating. Si Ating, yes. Ating, recognize.
Okay.
Okay, shall I call on Miss Ate Mercy? Thank you, Ting. Ate Mercy. Mercy Kiamko, wala pa. Then, last but not the least, Miss Claudette Rabago. Na? Okay, so, let me call on the others who were not able to have their attendance check. Miss Jeanette, last call. Jeanette Ibarola, wala gyapon. Si Ate Mercy.
Brown out sa tugod, sir, sa bukid.
Brown out? Okay. So, if anybody makakontak ni Miss Jeanette, kindly advise her to please find a connection, find some ways maka-connect siya to be able to join us. And Ate Mercy, last call, Ate Mercy. Okay, so I guess they'll be joining us later. And thank you for your participation. So shall now hand over the program to our MC. Thank you.
Hi, Day.
Thank you so much, Sir Amante Damayo. Now to begin our program, let us all welcome our Education Program Supervisor, Ma'am Arlene Manginsay, for the opening remarks and the rationale of this activity.
Warm greetings to everyone. Happy Wednesday. I would like to express my warm welcome, especially morning greetings to our Schools Division Superintendent, Dr. Gilberto Oplinaria, our Assistant Schools Division Superintendent, Dr. Rosemary T. Masisar, our SGOD Chief, Dr. Maria Camila Ablin, and Dr. Maria Eva S. Idon, our CID Chief, to all Health and Nutrition Section personnel, headed by Dr. Milvin Inerio, to all Division Office personnel, in all the focal person of the tuberculosis program. Once again, good morning. According to Mal Kwanan, fighting against tuberculosis unremittingly is the slogan for this year and depicts our goal in the future. So in compliance of Executive Order number 187, series of 2003, this instituting a comprehensive and unified policy for the tuberculosis control in the Philippines. DepEd Order number 44, series of 2004, which emphasized strengthening of the implementation of tuberculosis prevention and control program. To adhere on the above endeavor, the Division of Lanao del Norte conducted this webinar to raise awareness on the TB prevention and control program. This is also to detect early signs and symptoms of the importance of tuberculosis course medication. I guess we have our resource person for this virtual activity that could enlighten us on this program, especially on the prevention and control of tuberculosis. So as health personnel in our division, it is our duty to really cascade what we have learned in this gentlemen. I believe that participating in this webinar really find new ideas, fresh energy, and noble partnership to sustain our effort in the support of anti-tuberculosis program in our division. So according to Dan Ornes, poor health is not caused by something you don't have. It caused by disturbing something that you already have. Healthy is not something that you need to get. It's something you have already if you don't disturb it. So in behalf of our Assistant Schools Division Superintendent, Dr. Rosemary Tulud Masisar, I am pleased to welcome you to this webinar in tuberculosis. Once again, good morning and God bless everyone.
Thank you so much for that wonderful opening remarks, Ma'am Arlene. And now, without further ado, let us all welcome our first guest speaker for today, none other than Dr. Aminuddin D. Pamanay, Doctor to the Barrio of Matungao, Lanao del Norte.
Hello, good morning. I think thank you for that introduction. My lecture's
Good
been
morning, everyone,
pre-recorded
and
and will
thank you for
be.
that kind introduction. First off, I would like to express my gratitude to the Board of Education of Lanao del Norte, headed by Dr. Gilberto El Opinaria, the school's division superintendent. Also to Dr. Rosemary P. Macesar, the assistant schools division superintendent. Dr. Maria Carmela T. Ablin, the chief of schools governance and operations division. I am PB in schools and offices. And I presume that this webinar is attended by school nurses and school tuberculosis focal person. And this recording is intended for DepEd personnel of the Division of Lanao del Norte. So this is my quick background as I was introduced a while ago. Currently, I am the officer in charge or municipal health officer of the municipality of Matungao, Lanao del Norte, under the Doctors to the Bars program of the Department of Health. For today's webinar, our objective is number one, to have a background of pulmonary tuberculosis, a quick review, and to know the burden of TB disease and what are the guiding principles of TB control and what are the current recommendation strategy to promote infection prevention and control that can be adopted in schools and offices. Throughout this webinar session, we will be utilizing the WHO guidelines for workplace TB control activities and as well as the guidelines on tuberculosis infection prevention and control, the 2019 update. So what is TB? TB is an airborne infectious disease caused by organisms of the Mycobacterium tuberculosis complex. Although primarily a pulmonary pathogen, Mycobacterium tuberculosis can cause disease in almost any part of the body. Infection with TB can involve from containment in the host to a contagious state in which the patient will show symptoms such as cough for more than 2 weeks, fever, night sweats, and weight loss. These are the notable symptoms of patients with TB disease. But only active pulmonary TB is contagious. And in many in what is the burden? With a burden of disease that accounts for more than 10 million new cases per year, of which less than two-thirds are reported. age less than 15 years old, reflecting an ongoing community transmission. So before embarking on workplace TB control, it is important to us to review the following principles for implementation. All employers, stakeholders involved in TB control should respect this, especially the health staff in contact with the affected employees, usually school person. Number one, in general, we need to protect the patient. So number one, always respect the patient's rights. Maintaining a confidentiality of medical conditions and medical records is crucial to giving employees confidence to undergo treatment. Lack of confidentiality can lead to discrimination as well as delayed diagnosis and treatment. Confidentiality means that only the staff directly involved in the individual patient's medical care know that the patient's medical status and have access to his or her records. Medical staff should never divulge the medical status of employees to any other workers or to the management. Number two principle is to offer social welfare benefit to TB patients and their families. Social welfare provided to workers and their families can help patients complete treatment. Welfare benefits may consist of free treatment and services, maintaining salary during treatment, or providing compensation for loss of income, free transport to health facilities, and food support. Importantly, to motivate the patient to continue treatment, social support should be adapted to the delivery and duration of the treatment. Currently in the Philippines, social welfare benefit is being offered in partnership with the PBSP to those patients undergoing treatment for TB. Number three is to help TB patient to tailor their workload task to their state of health. For at least the first 2 to 4 weeks of TB treatment, a patient should be on leave of absence, with arranged for his or her convenience. The employee may often then resume work if necessary with an adjusted workload and modified tasks until fitness returns. For example, it may be possible for an employee who is normally engaged in heavy labor to do office work for a few months. We also need to ensure a safe workplace environment for us. Number four is to use education campaigns to decrease stigma. Effective health education campaigns should address negative attitudes towards people with TB. Traditionally, TB is viewed as a deadly disease of the poor, and the strong social stigma it provokes makes it more difficult for people with TB to seek diagnosis and treatment. This can be countered by greater knowledge and understanding. For example, education should stress that everyone is vulnerable to TB, that most people with TB cease to be contagious or not infectious after 2 to 4 weeks of treatment, and that disease is usually curable. Number five is to develop and implement clear management policies. The employer's policies on confidentiality, discrimination, length of time off allowed for medical treatment, and job modification when necessary should be clearly outlined and made easily accessible. They should be clearly explained employees with such employees. Reducing the delay between onset of symptoms and diagnosis and treatment is crucial to the decreasing risk of TB transmission. And lastly is to implement environmental controls. Environmental controls of TB refers to implementing environment-associated interventions to prevent or reduce airborne transmission from unsuspected cases or from diagnosed cases of TB to non-infected employees. Most TB cases are a result of airborne transmission infection. Environmental factors that enhance TB transmissions are small enclosed spaces, areas that lack sufficient ventilation to clean the air through dilation or removal of infectious droplet nuclei or ventilation systems recirculating air. Let's talk about TB infection prevention. The evidence-informed recommendation on TB infection prevention and control is developed in the context of the global targets of the Sustainable Development Goals and the World Health Organization and TB strategy. Interrupting the cycle of Mycobacterium tuberculosis transmission is crucial to achieving global targets to end the TB epidemic. Thus, there is a need to implement interventions to rapidly identify source cases, impede person-to-person transmission by reducing the concentration of infectious particles in the air and the exposure time of susceptible individuals. These principles form the basis for effective infection prevention and control. The recommendations given here on TB-specific interventions are not envisioned to be stand-alone measure. Rather, they are comprehensive hierarchy of controls, which in turn is a component of the overall framework of IPC practices and depends on the adoption of a multimodal strategy. There are 7 general recommendations on infection prevention controls, and they are grouped into 3: administrative controls, environmental controls, and respiratory protections. There are 4 recommendations under administrative control. Number 1 recommendation is triage. A set of administrative controls is the first and most important component of any IPC strategy. This scheme comprise specific interventions aimed at reducing exposure and therefore reducing transmission of tuberculosis. Triage of people with TB signs and symptoms or with TB disease is recommended to reduce Mycobacterium tuberculosis transmission to health workers, persons attending healthcare facilities, or other persons in setting with a high risk of transmission. Identifying TB presumptive involves asking people about symptoms of TB when they present at health services. And the most important symptoms of pulmonary TB is cough for 2 weeks or more, associated with fever, night sweats, or weight loss. So we need to identify in our employees, in our co-workers, who among them having the symptoms, and recognize TB presumptive, so that we can go to number 2. Recommendation number 2 is respiratory isolation. Respiratory separation or isolations of people with presumed or presumptive TB is recommended to reduce Mycobacterium tuberculosis transmission to health workers or other persons attending healthcare facilities. Respiratory isolations is common practice in health facility. If they are identified having the presumptive TB cases, they are put in a room or separate area for them to be entertained, or for them to identify or for them to undergo tests and diagnostics to establish diagnosis of TB. What do we do about in the workplace or offices? So we could identify a place where we can consult, where we can entertain our co-workers having symptoms of TB. And recommendation number 3 is the initiation of effective treatment. Evidence continues to mount that delays in initiation of effective TB treatment increases the probability of onward transmission of the disease. TB treatment has a direct effect on survival of TB patients. It also has the potential to directly decrease tuberculosis transmission, provided the treatment is effective and administered in a timely manner. So as a school nurse or focal person, what is our role in the initiation of effective treatment? We play a significant role. Number 1 is the referral of cases to TB Center in Lanao del Norte. And then we can be also a partner in the directly observed treatment. If the employee started to report on work after 2 to 4 weeks of leave while initiating the treatment. We can be the partner in the administration of directly observed treatment to our employees as they resume their work or report to schools or offices. So we can be, we played a vital role in the treatment of our employees. Recommendation number 4 is respiratory hygiene, including cough etiquette. To reduce the dispersal of respiratory secretions that may contain infectious particles has been used as an additional measure to prevent TB transmission. Although there is a literature on understanding the dynamics of cough aerosols of tuberculosis, data for comparing the effectiveness of respiratory hygiene maneuvers are scarce, especially the data on humans. Respiratory hygiene is defined as the practice of covering the mouth and nose during breathing, coughing, or sneezing. This can be displayed through wearing surgical mask or cloth, or covering the mouth with tissue, a sleeve, or a flexed elbow and hand, followed by hand hygiene. To reduce the dispersal of airborne respiratory secretions that may contain tuberculosis bacilli. In schools, we can promote this practice by posting reminders, posting infographics on how to do respiratory hygiene, and to continuously remind our workers, students also to practice the cough etiquette when they are coughing or sneezing. So we are done with the 4 recommendations under administrative controls, and we move to environmental controls. Recommendation number 5 is the use of upper room germicidal UV system. To reduce the risk of transmissions of Mycobacterium tuberculosis, air can be made less infectious through the use of 3 principles: dilution, filtration, and disinfection. Environmental controls are aimed at reducing concentration of infectious droplet nuclei in the air. And this is achieved by using special ventilation systems to maximize airflow rates or filtration, or by using germicidal ultraviolet system to disinfect the air. Ventilation system can also be used to control the direction of airflow to reduce the spread of infection. For example, through the use of exhaust fan to generate a negative pressure gradient. Environmental controls are used in combination with other IPC measures to help prevent the spread of Mycobacterium TB. Among of the environmental controls, upper room germicidal UV system can be considered as magastos. So there are other options. Recommendation number 5 is ventilation system. The natural ventilation is the preferred ventilation system in resource-limited settings where there is a high risk of TB transmission. However, the use of mixed-mode ventilation, mechanical ventilation, or high-efficiency particulate air filters may be more appropriate in settings where natural ventilation is not suitable because of the climate or other constraints. In offices using air-conditioned room, what we can do is we can institute filtration system through HEPA filters. No, HEPA filters is the principle also behind of what we know the using of air purifiers. Natural ventilation is the preferred system in settings with no constant electricity supply. In resource-limited settings, such as schools located in far-flung barangays with no electricity or no constant supply of electricity, the most commonly used ventilation system is natural. So what do you mean by natural? It is simply opening windows and doors, promoting the inflow and outflow of air. And the last recommendation of the WHO in the 2019 guidelines is the use of respiratory protection. Respiratory protection controls are designed to further reduce the risk of exposure to TB for health workers in special areas and circumstances. Particulate respirators within the framework of a respiratory protection program are recommended to reduce the tuberculosis transmission to health workers, to staff attending healthcare facilities, or other persons in settings with a high risk of transmission. What are these particulate respirators? Among of the well-known particulate respirators are N95, or the one that you can see in the slide. No? So this can effectively filter 95% of the particulate matter that could prevent the transmission of TB. In our I highly suggest that nurses, school nurses, and focal person have supplies of N95 so that they can use it during attendance to patients with presenting symptoms of pulmonary TB to protect themselves also. So I think in summary, these are the takeaways for this morning's lecture. That TB is an airborne infection and still continues to be a global health threat with an estimated 10 million cases per year, and that the workplace offers a good opportunity for TB control activities. And those 7 general recommendations on TB infection prevention controls are not standalone, but they work hand in hand as an integrative approach in preventing TB infection to end the TB strategy. So I think that would be all for this morning's webinar. I would like to thank Ma'am Patri Dumato for the assistance and constant reminders for me to be able to join you in this webinar. I originally I would love to discuss it live, but then I have another schedule for vaccination in Matungao, so that I have decided to pre-record this session. I will be joining you in the question and answer, or in the open forum, to address questions if you have. Please reserve your questions for the open forum. Thank you, and reminders, always wear your face mask, and then get vaccinated if you are priority group, if you belong to the priority group, and then always access the right information. Huwag maniwala sa sabi-sabi lang. So that would be all, and thank you.
Thank you so much, Doc Mensch Pamanay, for the information of the preventive practices to hasten the risk of acquiring tuberculosis in the workplace. Thank you so much, Doc Mensch. Doc Mensch was my senior during my nursing days in MSU Marawis. Thank you, Doc. Hi. And now, let us all welcome Ma'am Saisa Interina for her insights about TB referral system in Lanao del Norte.
Hello, good morning. Makita akong screen.
Yes, ma'am. Good morning, ma'am.
Okay, thank you. So before anything else, I would like to congratulate everyone, especially the focal person for this program, the TB program, for conducting this kind of activity. So this is the first time that I am gonna discuss about TB, because technically, in my 4 years in the program, I only have discussed HIV with the DepEd personnel. So before anything else, I would like to thank our heads of the Department of Education Lanao del Norte Division, headed by Dr. or rather Sir Idelberto Oplinaria, our Chief Superintendent, Division School Superintendent, our si Ma'am, ano ba yung name? Nawala yung picture ko. Wait. Our division heads, Ma'am Manginsay, Arlene Manginsay, our SGOD chiefs, Ma'am Ablin, and the rest of our colleagues in the different schools and also in the health section of the division office of DepEd. So this morning, I am tasked to present the statistics of tuberculosis in Lanao del Norte. So for case detection, so these are the cases that are reported in our rural health units or the DOTS facilities. We have two categories of TB. First is our drug-susceptible TB. So we call this in layman's term the normal TB. So annually, we have a target of 4,079 cases to be detected or treated. In 2020, we only got 1,249. So that's roughly 40% only of the target. For the first quarter of 2021 until the second quarter of 2021, out of 1,119 quarterly target, we got 732 for a total. For drug-resistant TB, we have an annual target of 213, but we only, unfortunately, detected 36 cases for the entire province last year. And for the first two quarters this year, we have a target of 53 quarterly, but we were only able to detect 26. So in all 22 municipalities in the province, I ranked the areas according to the most number of cases reported. So number 1 is Lala, second is Sultan Naga Dimapuro, third is Kapatagan, fourth is Ubod, and fifth is Paloi. So these are the case areas that have a lot of cases reporting to the RHUs, and also these areas have conducted their we call this active case finding. They did our community assessment among possible or presumptive TB cases. Demographically, according to sex and age, in 2020, these are the percentages according to sex. For our drug-susceptible TB, males ang majority. So that's 64%, followed by females, that is 36%. Whereas in drug-resistant TB, we have males, 68%, and females, 32%. So technically, no, daghan yung lalaki na taptan og TB. According to age, for our drug-susceptible TB, majority, the top one, according to the incidence rate, belong to the 45 to 54-year-old age bracket. And this is followed by 25 to 25 to 45, sorry, not clerical error. 25 to 45-year-old age bracket. So if you will check this one out, these age brackets belong to the working class. So naatay mga nagtrabaho sa manufacturing, nasa food sector, naay teachers, naay nurses uban. So these are technically working class. For our drug-resistant TB, according to age, male 68 and sex, male 68%, females 32%. But according to age, layo kay siya diferensya no sa pikas. 15 to 24 years old ang number 1. This is for the entire Philippines. 45 to 54 years old po siya when it comes to the age. Ang second nga when it comes to incidence rate. So if you will check daghan siya sa 15 to 24 years old. So, according to the statistics po nga among gina-discuss regionally, this age are the most active ni siya. And then naapod siya cases nga within these cases, this number of people ani siya is naatay mga HIV positive cases among these cases nga nagbilong ani nga age bracket. In the entire Philippines, no, parehara siya sa ato halos-halos sex, males all forms meaning drug resistant or drug susceptible TB, that's gonna be 59%, and females 31%. Gamay layo-layo siya diferensya like mga 10%, no, when it comes to in comparison sa Lanao del Norte. When it comes to age, 15 to 24 years old ang daghan in the entire country, and this is followed by 45 to 54 years old. So, technically, mga nanarbaho na gid siya ng mga edad. So, this is gonna be maybe nakuha nila sa workplace or kauban nila sa balay. So, in our case, in Lanao del Norte, these cases, drug resistant TB, especially karon pud siya nga year, most of the drug-resistant TB are kapamilya. Let's say, for example, we have one case in Gida area in Lanao del Norte. We have one index case nga ang papa. When gitest ang entire family, 3 of the members of the family turned out to be also drug-resistant TB. So it is very important to contact trace every member or every contact of the index case of our TB cases. Lalong-lalo na if drug-resistant TB, because they have like 20-fold chance of transmitting the disease to their close contacts compared to drug-susceptible cases, which is a lesser lang siya, half of the chance of transmitting disease to their family. In terms of treatment success rate, so technically sa drug susceptible TB, we have a very high na success rate, but still it's not 100%. Although the target in the national level is just 92%, but if we are gonna treat TB, we should also always aim to treat 100% of the cases. So no, although nag-increase siya, still we have deaths that we have met deaths that are TB related in the past year and early this year in first quarter of 2021. For drug-resistant TB, we only got 47%, very, very small. So the target is 87%, supposedly. We only got 47%. So where did these people go? Where did these patients go? Some have died, some ay nanago na. So that is the main problem from us sa public health sector. Most of our drug-resistant TB ay manago. Maybe because of the treatment of drug-resistant TB is very rigid, and it had injections daily for several months. But thankfully, with the researchers that have came up with new treatment modalities, treatment of DRTB or drug-resistant TB is now all oral regimen, unless dili ka pwede sa treatment nga proposed for you. So nanatay mga injectables later if you are resistant to those drugs. For our top 5 municipalities with poor treatment outcomes in all forms, Salvador is number 1. So basically, for 2 years, last year they had 5 deaths. This year na pod, in the first half of the year, they have 3 deaths na. So that is quite a lot when we compute it with their number of cases. That is more than half na siya. almost more than half. Next is Tutanaga di Mapuro. So meron tayong, we have a lot of DRTB cases in SND who have been lost to follow up. When we say lost to follow up, meaning they cannot be found na. May nagtatago, and then some of them do not answer the calls of the DOTS nurse or the NTP nurse or the satellite treatment center. Majority of the failed cases of SND are drug-resistant TB. So in our level, in the PHO and the regional level, we would consider SND to be a hotspot when it comes to drug-resistant TB. Several na ang nag-lost to follow-up or nag-quit sa ilahang treatment. Like, nag-treat lang for a month instead of 6 months. So that is very poor prognosis. Third is Baroy. So last year, they had death. As per investigation, 50% of the death is due to COVID, 50% is due to TB, gyud siya. So complications of TB disease, and left na siya na poor ang iyahang treatment adherence. Next is tubod. We have deaths, anemia. So when investigated, according to the NTP nurse, the death is one accident. Ang isa is cancer. And so fifth placers, we have Balui and Maigo. So gamay ra sila case si Maigo, but then some of their cases, especially in Maigo, the drug-resistant TB do not continue their treatment. So that's the problem gyud siya when it comes to the RHU. Balui, we have 1 or 2 DRTB cases who are lost. As per investigation by the assigned personnel in Balui, nagbalhin na siya og SOR. And then Lanao del SOR, and then wala pa siya na trace. So wala siya na trace gyud kay nag-deny siya sa iyahang address. Pag dito nawala na siya sa iyahang balay. So that's the problem when it comes to drug-resistant TB. Grabe sila kay. So drug-resistant TB, they are gonna be drinking a minimum of 20 tablets in a day for 6 months. And that's gonna increase depending on your weight. So gamay lang na siya ang 21. Whereas a drug-susceptible TB, minimum is 3. Mo na siya 3 tablets. And mag-increase siya when your weight increases along the course of the treatment. That's gonna be 6 months. So the drug-resistant TB, wala siya Q1 and Q2 because most are ongoing pa ang treatment, and our cohorting or our real treatment success is going to be computed based on a 2-year period because we have a 6 months treatment, some are on the 12-month treatment, some are 18 months. So, and then we have another 6 months plus another 6 months to test if they're really negative, wala ba siya relapse during the period of 2 years sa ato ang drug-resistant TB treatment. So what are the consequences of poor treatment outcomes or incomplete treatment? So I know, I think the discussion ni Doc earlier. So number 1, Jod, is development of drug resistance. We do not want to develop drug resistance. Why? Because we will become a multi-drug, monodrug, or polydrug resistant TB case. What does that mean? So we are going to be resistant to at least isoniazid, rifampicin, which are the most potent TB drugs. Meaning mo na siya ang pinaka-effective na drug when it comes to our drug-resistant TB. For example, if you're gonna abruptly stop, wala naman kay giubo, sa mundang na akong inom ni rifampicin, ni Ripes, ni rifampicin, isoniazid, pyrazinamide, ethambutol, ni Ripe. Wala na tayo streptomycin sa atong treatment, so Ripe na lang na siya. So if muundang ka, there's a very high chance that you're gonna develop resistance to these 2 medications who are considered the first line of defense of your body against tuberculosis. And then if ever you're gonna stop treating yourself for multi-drug resistant TB. Next na po, Ana, is you're gonna go to the next level, which we call extensively drug-resistant TB, or we call this in joke term, the mutant TB. So this is a rare type of MDR TB which is resistant to isoniazid and rifampicin, plus any fluoroquinolones or at least one injectable drug, second-line drug. So imagine you are resistant to the first-line drug, plus you are resistant to the second-line drug. So you are very social na ni ang tambal ani niya. So the current treatment regimen for MDR-TB, number one treatment is your bedaquiline that costs $1 million for an entire bottle, a bottle of 100 tabs. O 1 million na siya. So when you are an XDR-TB or MDR-TB, you are considered a millionaire because million ang imong tambal nga ginoom. And just one of the drug, the bedaquiline is just one of the drug that's given for MDR-TB cases. Next is, of course, death. So the Philippines ranks 9th among the 22 high burden countries for TB. So imagine, Philippines, how many million are we only? 104 million? And then compared to other countries who have higher population than us, 9th in the entire world. 9th among the 22 high burden countries. Our death rate in 2019 is 25 in 100,000. So, Monisha, no? In the Philippines, HIV negative TB mortality rate, meaning if the TB case is HIV negative, the mortality is 26,000. So, sa tanang cases detected as TB, reported as TB who are HIV negative, 26,000 of it would die from TB. Whereas for HIV positive, we have 600. So I believe this is quite low because our TB karon is dili pa gyud kay siya inana ka-establish ang HIV testing among TB. So in terms of population in millions, we have 108,000 deaths in millions. So no, why would I say that this is quite low? Because technically na pila lang sa Lanao del Norte, for example, ang naay HIV proficient medtech, and it has been established by the national government that HIV testing should be made mandatory for all TB patients because TB is one of the complications of HIV. So TB will not really be treated if HIV is not treated. So kailangan tandem siya in terms of treatment. So they are we call that two cases as the double-edged sword of the infectious disease cluster. So daghang mamatay ni TB if dili matreat pod si HIV. Okay. So when it comes to management referral, technically, mo ni siya nga tong flow, no? For clinic consultations and hospital admissions or OPDs, first is mag-accomplish, the NTP nurse will accomplish the referral form. So for example, in the school setting, one of your students, the school nurse have detected that the student has cough for more than 2 weeks, the clinical signs, classic signs, the symptoms of TB, the nurse can fill up this NTP referral form and then submit it to the nearest na referral facility, which is your DOTS facility. For nanatay private, diri sa Lala only Maranding Community Hospital or Tabanao Hospital. The rest of the RHUs are offering DOTS treatment. So from the clinic in the school, pag na teacher or na student that has 2 weeks or more cough and other signs and symptoms of TB, or you have learned that the family member is a contact of, is at is a positive case, especially if DRTB, pwede kang, the nurse would contact the RHU, and then the NTP nurse of the school will be the one to collect the sputum and refer it to the DOTS facility. Mag-coordinate lang si nurse pa DOTS and si school nurse. And then next one, after accomplishing the referral form, the patient and the significant other and the DOTS nurse will meet, no, mag-meet sila. And then schedule siya og gen expert examination. We do not do DSSM or smear microscopy anymore because we are trying to detect more DRTB cases and ensure that the ones we are treating with DSTB treatment are real DSTB. Because we have instances like in 2019, there was one private clinician in the nearby city. Nag-treat siya og isa ka case, private case, and then it turned out that the case is drug-resistant TB. So there, wala siya, burden financially when it for the client. So we are trying to limit the gastos of our patients. So as much as possible, we have to have an accurate diagnostic test result. So Gene Expert is our gold standard test when it comes to detecting TB, especially drug-resistant TB. So muna siya, pag ma-schedule na siya, and then we will go na dayon sa atuang next flow, which is the clinic consultation. Pag nana siya, laboratory request form, schedule sa treatment, and then magkuha siya og hukal, magkuha sa iyahang sputum sample, and then it will be subjected dayon to the testing. This is our machine. So this would run for only 45 minutes, makakuha na rin tag result. After that one, if the results are in, the patient will then be scheduled for the initiation of treatment. But if the result is drug-resistant TB, so in our case, we detect rifampicin-resistant TB, or we call that RRTB, the patient will be referred to the nearest satellite treatment center, or our PMDT satellite treatment center that is in Kulambugan RHU. But the one that will refer that is our NTP nurse from the DOTS facility in the RHU. So after referring to the STC, si STC nurse na dayon ang mag-initiate sa iyahang treatment because i-test pa man na siya, daghan pa kay siya og laboratory nga agian before the actual initiation of treatment. So yeah. So where are our Gen Expert sites? So our functional sites are here. This is the first Gen X site in Lanao del Norte, our LNPH in Baroy. Our two newest, Kapatagan Rural Health Unit, Lala Rural Health Unit. No, that's not Kulambugan Provincial Hospital, nalibat ako. That's Kulambugan RHU. And then Iligan Society of Internists, our RTDL site is found in GTLMH. I think if they have not transferred yet, bati na katulang building dito, but ilahang original site is at City Hospital. City Hospital ba na? Yeah. And then nearby is our Mars MC RTDL site. So pag naanay result, from here, the results will be taken by the strider or our sputum transport rider, and then this will be referred to this will be sent back to the requesting units. For example, si SND, nag-request siya o sputum exam, Gen X exam from Kapatagan to Kapatagan Rural Health Unit. So upon accomplishing the test, Kapatagan RHU through the strider will send the result to SND, and SND will then begin the treatment of our client. Gene Expert site to be operational soon. So I just talked with the regional office this morning. So nakaschedule na daw siya within the next 2 months, SND RHU and Kauswagan RHU as well as Balui RHU. So these are our 3 additional Gen X sites that will be open this year. Hopefully, we're gonna reach our target in detecting more TB cases in Another Norte because technically, daghan pa kayong nagtatagong TB dyan sa kilid-kilid. So, I guess that would be all my presentation this morning. For questions and queries on TB, you may message your respective RHUs or our page sa Facebook. This is our link, and thank you so much for listening.
Thank you so much, Ma'am Saisa. That is so informative. I'm sure our audience learned a lot from you. So at this juncture, let us give some time for some questions now. Please be sure to write down your questions in your control panel. Participants may also contact your district nurses for your questions. Our guest speakers are available and online to accommodate your queries to their respective presentations. Anyone? I think the nurses are still preparing for their questions to our presenter. Sir Amante, do you have any questions? Doc Melvin?
Not so far, ma'am. Very comprehensible. Thank you.
That's a nice feedback from one of our participants. How about Ma'am Kat Putes? Do you have any queries to our guest speakers?
Good morning, none so far.
Ma'am Rosie?
No, ma'am.
How about Sir Jasper? Sir Jed, do you have any questions? Sir Earl? Sir Yas? How about Sir Yas?
None, ma'am.
Ma'am Larnie? Ma'am Larnie? How about Ma'am Jeanette Ibarola? Do you have any queries to our guest speakers?
So far, none, ma'am. Thank you.
Anyone? Wow. I think our nurses don't have questions to our guest speakers. So thank you so much to our guest speakers for today's webinar, and we hope to see you again in the upcoming webinars in our school health section. Thank you so much, Doc Mensch Pamanay and Ma'am Saisa Interina.
Ma'am Kim, before we exit, I would like to invite our nurses or DepEd personnel in the division. I have an upcoming event on August 10 and 12. I have a mobile chest X-ray caravan in the Capitol. So if ever you want to get your digital chest X-ray, so available atong digital chest X-ray on those dates, August 10 and 12 po.
Thank you so much for the invitation,
Free, ma'am,
ma'am.
free.
Okay, thank you so much for the invitation, ma'am. Okay, it looks like our participants don't have any questions. So to wrap up our event today, let us welcome the officer in charge, the school health section, Dr. Melvin Inerio for the closing remarks.
Okay, thank you so much, Kim. On behalf of the Schools Division Superintendent, Sir Oplinaria, our Assistant Schools Division Superintendent, Ma'am Rosemary Tulod Masar, our SGUD Chief, Ma'am Maria Carmela T. Ablin. We would like to thank our partners in public service, in public health, no, ang ato ang mga resource speakers karong adlaw sa atong webinar. Ato ang mga brilliant speakers, Dr. Aminuddin D. Pamanay, the Municipal Health Officer of RHU Matunggaw, Lanao del Norte. Salamat kaayo, Doc Aminuddin, sa imuhang time o pag-share sa imuhang knowledge sa atong mga participants. And also to Ma'am Saisa B. Interina, RN, our infectious disease coordinator sa Provincial Health Office, Lanao del Norte. Salamat kayo, ma'am. Si Ma'am Saisa ato na gini siyang suki kanunay, no, sa ato ang mga programs, health programs sa DepEd. Kanunay gini siyang ato ang masangpit as our resource speaker. And also thank you for the dedication and efforts of our division PTB focal person, Ma'am Patri Raifa Domato, and to all the division health personnel, ato ang mga program holders, ato ang mga district nurses in attendance, all SGUD personnel, the schools focal persons of PTB. Daghan kay salamat jud sa time inyong gihatag alang sa pag-attend, no, ani nga webinar. Dili ni mahimong successful kung wala mo, no, karong buntaga. PTB occurs in every part of the world, but we can prevent the spread of this communicable disease through our collaborative efforts. Together with our health frontliners, we in the education sector has a vital role in the prevention of the spread of TB through information and health education. I hope that the information and knowledge shared to us by our speakers will be cascaded to our school populace, and thus making our school premises a healthy and safe place for our teachers and learners. Again, thank you for participating in this webinar. Stay safe, everyone, and have a blissful day ahead. Okay, Ma'am Kim?
Thank you so much, Doc. Thank you so much, Doc Melvin, for the closing remarks. Reminding everyone for the action plan forms or draft for school and district implementation of tuberculosis program. This will be sent to email the school nurses emails from the TB focal person. So that's all for today, everyone. We appreciate you being here. We would like to acknowledge again the presence of our guest speakers. Thank you for imparting your knowledge regarding to hasten the risk of acquiring tuberculosis. We would also like to thank everyone who made this webinar series possible. Thanks again for joining us today, and reminding everyone to answer the feedback form or the evaluation form of this webinar. I am Kim Rose Buklalaw Ibol, and see you next time. God bless us all.
Bye. Thank you. Thank you. Bye-bye.